the pace of the video. These are things like dissolves between shots or fades, which give the feeling of time passing. Another fun transition is the wipe, which can come in a lot of different styles. Some programs have automatic transitions as well as many options to customize them exactly the way you want. Step 8. Watch over and over, pause, and do it again. Watch your video sequence down over and over again. The more times you watch it, the more you'll feel when it gets too slow, or where you need to edit something out, or if you need.
And then we have a CME educative session, which will be next. And to chair the first session, I'd like to invite Dr. Shankar Atavale and Dr. Rushikesh Kharosekar. And my request to the speakers is to please stick to time. There are also awards for neurosurgeons, neurologists, as well as allied subjects in this paper. So Dr. Shankar Atavale and Dr. Rushikesh Kharosekar, please take over.
I'm Dr. Shankar Atavale. Good morning, all of you. First and foremost, I want to thank Dr. Varnan and the BNA committee for giving me the opportunity to chair the session. To start with, already we are late. To start with, I would like to call Dr. Abhishek Gaikwad, and he will talk on Takayasu arteritis. Doctor, over to Abhishek. Abhishek, is he around?
Yeah, Abhishek. Yeah, you start. Abhishek is mute.
Hello, is I audible? Yeah. Am I audible?
Yes, go ahead.
One of the leading cause of death and the disability in the India, and almost in young group, it constitutes almost 10 to 15% of strokes. Now, coming to the etiological factors in a stroke, if you look at the pyramidal structure, you have excuse me, how can I hide that side window? Yeah.
So Abhijit, on upside there is minimize arrow.
Yeah. Okay. Got it. If you look at the stroke pyramid, the large portion is formed by the atherosclerotic large artery disease that forms almost 21 to 40% of young strokes. Then we comes at non-atherosclerotic large artery disease, such as the dissection, that constitutes almost 10 to 33% of young stroke. And we come at prothrombic state, that constitutes 8 to 15% of strokes. Then the penetrating artery disease, that constitutes 3 to 18%. And finally, the unusual causes of stroke in young, such as SLE, fibromuscular dysplasia, and vasculitis. Now, the Takayasu arteritis is a rare granulomatous vasculitis of large and medium-sized arteries. Worldwide incidence being 1 to 2 per million people per year, and it is predominantly affecting the Asian population. And the incidence being almost a double, as mentioned. And it predominantly affects the female more than a male in their 20s. The presentation of Takayasu being the variable from the diminished pulses to the ischemic stroke, and the incidence of stroke being the 5 to 17%. The Takayasu should be kept under the differential diagnosis of stroke in young patients, because the early proper diagnosis can reduce the further propagation and the mortality. Here we present the two variable neurological presentations that can form in Takayasu. Now, coming to the case 1, the 32-year-old female presented in OPD with acute painless diminution of vision in right eye since 15 days. She had no any sensory or motor complaints, and she had no any comorbidities. On examination, patient was conscious and well oriented. Bilateral upper limb pulses were absent. There was buoy over the right carotid artery, and bilateral BP in lower limb was 190 by 110. Vision in right eye was affected to the finger counting up to the 3 meters. In the left eye, it was 6 by 6. The relative apparent papillary defect was in right eye, with fundoscopy revealed the right eye disc edema. The perimetry revealed the inferior altitudinal defects in right eye, Its power and sensory examination was normal. Patient was started on injection methylprednisolone 1 gram IV OD for 5 days. On the third day, the patient developed sudden onset of light-sided hemiparesis with EMA type of facial left-sided facial palsy with dysarthria. The CT brain suggests the acute non-hemorrhagic infarct in right middle cerebral artery. Where blood investigations were normal, except the ESR was high, 75 mm at 1 hour, with C-reactive protein was positive. Otherwise, ANA was negative and the coagulation profile was also normal. VV suggests the reduced amplitude and normal latency in the right eye. The echo was normal. When he did the MRI brain and top neck angiography, that revealed the narrowing of right brachiocephalic artery and the loss of signals in the proximal right vertebral and the common carotid artery. The clinical scenario of absent upper limb pulses and the ischemic stroke raised the suspicion of large vessel arteritis. We did the CT angiogram, and that revealed the diffuse brachiocephalic artery wall thickening. On the basis of clinical examinations and laboratory results and the prominent CT angiogram findings, the presumptive diagnosis of Takayasu arteritis was made. Patient was started on high dose of steroids. Injection MPS was given 1 gram IV for 5 days, followed by oral prednisolone at the dose of 1 mg per kg per day with methotrexate started at 15 mg per week. That was increased by 5 mg per week till the dose of 25 mg per week with the aspirin. And there was marked clinical improvement, and that was followed with ESR with CRP levels. Now coming to the case 2, the 20 years old primary gravida without any comorbidity was referred to neurology with history of generalized headache, vomiting for 4 days, followed by 2 episodes of generalized tonic-clonic convulsions and altered level of consciousness since 1 day. On examination, patient was drowsy. She was responding to deep painful stimulus, and Glasgow Coma scale was 9/15. The bilateral upper limb pulses were absent. Deep in the lower limb, 210 by 110 mmHg. There was left extensor plantars. Blood investigation was normal, except there was increase in ESR, CRP. Otherwise, lipid profile, homocysteine, as well as coagulation profile was normal. Echo was also normal. When we did the MRI brain, the SWI image revealed the blooming in right corona radiata with the intraventricular extensions. And also, the MR venogram revealed the thrombosis of superior sagittal sinus, and also the left transverse and the sigmoid sinus thrombosis. We did the CT aortogram. The coronal image reveals the aortic wall thickening and the complete occlusion of left subclavian artery and the severe narrowing of proximal left common carotid artery. Based on the clinical findings and the aortogram abnormality, the patient was diagnosed as a Takayasu arteritis. We started the anticoagulants for the severity in a dose of LMWH was given 0.6 ml/SC, BD for 5 days, and the steroid pulse with the followed by oral prednisolone, and the oral methotrexate was started at 50 mg per week, increased by 5 mg per week till the dose of 25 mg per week. Patient recovered after the week of treatment with the good clinical recovery. Now coming to the discussion, the Takayasu arteritis is also known as a pulseless disease. Is a chronic inflammatory disease of unknown etiology that affects the aorta and its branches. It was first described by Dr. Mikito Takayasu. He is a Japanese ophthalmologist in 1905. The female predominance is there, with more affecting the Asian population in the age group between the 11 to 30 years. The etiology being unknown, but it's supposed to be the autoimmune process. And some studies have shown the association with certain HLA, such as HLA-B52, and the autoimmune process such as sarcoidosis, inflammatory bowel disease, and in some cases there is association with TB also. Considering the more prevalence of TB in India, the association with Takayasu has been proposed with TB due to the cross-reactivity between MHSP65 and the HSP65. The MHSP65 is the mycobacterial heat shock protein 65, and the HSP65 is human heat shock protein 65. There is molecular mimicry, and that is the causing the autoimmune process. But remember, the TB arteritis is infectious disease, but the Takayasu arteritis is non-infectious disease. That is the main difference. And also the most commonly affected part in the TB will be the distal junction of arch with descending aorta. In the Takayasu will affect mainly the arch of aorta. Also the presentation of TB arteritis in half of the cases, that those will present with directly with aortic aneurysm, rather than the Takayasu will be having the stenosis and the embolism as a cause. Now coming to the clinical presentation, how the patients came. There are the two phases has been explained, the pre-pulseless phase and second is pulseless phase. In the pre-pulseless phase, patient will present with non-specific systemic inflammatory features such as fever, night sweats, malaise, and the pulseless phase, the patient will present with vascular insufficiency and compromise that will constitute almost limb claudication. He can be have hypertension and the neurological disease such as seizures, TI, strokes. Now, the stroke as a complication of disease of Takaisu, the estimated incidence is 10 to 12%. But stroke as a first manifestation of disease is very rare. And the etiological explanation is that it can be occlusive embolic stasis due to the stenosis, or there can be the aneurysmal formations. Now, coming to the diagnostic criteria, American College of Rheumatology has proposed the criteria in 1990 that constitutes almost the six criteria. And for the diagnosis, we should have the three criteria: sensitivity being 90% and the specificity being 97.8. That includes the age at the less than 40 years, claudication of extremities, decreased brachial artery pulses, blood pressure difference more than 10 mmHg, bruit over the subclavian arteries of the aorta, and the aortogram abnormality. But in this case, we should include the other possibilities such as atherosclerotic SLE and the fibromuscular dysplasia. Now, this criteria has been modified in 1996, and that is called a modified Ishikawa's criteria. Here, the difference is over that the age criteria has been eliminated, and there are the 3 majors and the 10 minor criteria. In the major criteria, they have mentioned the left median subclavian, right median subclavian lesions, and sign of symptoms of at least 1 month, and those symptoms are nothing but the that was the reason because of the pulseless phase. And the minor criteria, 10 minor criteria there. They are specifying the lesions of the artery. And the diagnosis, for the diagnosis, we should have 2 major, or 1 major, 2 minor, or the 4 minor criteria. No known serological marker exists for the diagnosis of the disease, but ESR is most commonly used, but it is not much reliable. Angiography is the gold standard for the imaging because 100% sensitivity specificity. We can go for the PETs. That will give you a more sensitive test for detecting the early inflammatory stigmata of Takaisu and to evaluate the disease recurrence and the response to the treatment. But we can have the alternate to the PET also, where the PET scan is not available. We can go for the CT angio and the MR angio that can give the clue according to the diagnosis, tracking the progression and the response to the treatment. Now, coming to the treatment part, the immediate priority is to treat the acute vascular compromise. For that, we can go for the thrombolytic, or we can go for the intervention revascularization. And the long-term goal is to decrease the vessel inflammation and progression of the disease. For that, glucocorticosteroid is mainstay of treatment. With the glucocorticosteroids, we should give the immunomodulators such as methotrexate, cyclophosphamide, and azithromycin. And if the patient is steroid resistant, even to the both of the 2 of the immunomodulator, then we can go for the biological agent that are nothing but the TNF alpha agents, infliximab and etanercept. Now, when to go for the endovascular surgery and the surgical revascularization? If the patient is having severe renovascular stenosis, extreme claudication, clinical critical cerebral ischemia, or the stenosis of 3 or more cerebral vessels, thoracic abdominal aorta more than 5 centimeters with tendency to rupture, or if the patient is having severe aortic coarctation. Now, coming to the survival, the 5-year survival is estimated to be the 80%, and it depends on the clinical manifestation of disease and the response to the medical and the surgical therapy. Now, going to be highlights are cryptogenic strokes in the young should include the Takaisu arteritis in the differential before we label young stroke as a cryptogenic, and we should keep in mind the variable neurological presentation of the Takaisu arteritis. Thank you for the patience.
Thank you, Abhijit. Thank you.
Presentation, Dr. Abhijit.
Yeah. Kamlesh sir, would you like to comment on this? Being the neurologist.
Am I audible?
Yes, sir.
Yeah, yes, sir. Yes.
Should always keep in mind as an cause of young stroke. It's often missed. Should have index of suspicion in the causes of young stroke. That's all.
One thing I would like to add in Takaisu's disease is newer imaging modalities like the vessel wall imaging in MR. It has equal efficacy as compared to the PET scan. Nowadays, more and more people are going for the vessel wall imaging. Only thing is it requires higher Tesla MRI and injection of contrast. It helps in diagnosing the acute phase of the Takayasu's arthritis if we are treating Takayasu's arthritis.
Thank you. I would like to invite the second speaker, Dr. Gaurav Gupta from Bombay Hospital, who is going to present on interesting case of posterior fossa tumor.
Good morning, everyone.
Yeah, good morning.
So, is a 12-year-old male child, right-handed, complained of gait imbalance, tendency to sway towards right for 12 days, diplopia on and off for 10 days, and headache for 10 days, and no other complaints. Now, on examination, positive findings were there were left gaze evoked nystagmus, hypostasia on the right side of the face, loss of nasolabial fold on right side, and left-sided facial deviation on smiling, and forehead wrinkling was absent on left side. The rest of the findings normal. Other cranial nerves, we see uvula divided towards the right and left palatal arch lower with gag impaired bilaterally, weaker more on the left side. Motor fiber 5, reflexes 2+, Babinski negative, tandem gait impaired, cerebellar signs were impaired on the left side. There were no meningeal signs. So these are the imaging findings. This is the T1 axial image showing a well-defined lesion, hyperdense, located in the pons, completely intrinsic. SAG image. This is T2 axial showing the hyperintense cystic lesion in the pons and with minimal perilesional edema. Flare, it is slightly hypochondrial as compared to the T1, but it is well localized. This is the contrast image axial showing a well-enhanced ring with central non-enhancing part. It is abutting the fourth ventricle, but no supratentorial hydrocephalus. These are the diffusion findings. No restriction on the diffusion weighted image. No restriction, no drop in the ADC. And GRE showing no products. And these are the middle cerebral peduncles that were deviated and displaced, not infiltrated. Similarly, corticospinal tracts showing displacement, no infiltration as such. So we plan to operate the patient, and these are the baseline SACPs and MMPs intraoperatively. We took a midline suboccipital approach, going through the floor of the fourth ventricle, opening the dura and going past the fourth ventricle. Then here we use the facial monitoring, facial nucleus. This is we use the intraop neuromonitoring for stimulation of facial nucleus. And then we took the approach above the facial colliculus. This is the facial nerve stimulation, and this is the intraop USG showing a cystic lesion. Just it's around 3 or 4 mm below our incision, and this is how we opened the cyst. This is fluid coming out. It was looking non-necrotic xanthochromic fluid, and this is the post-excision. This video showing removal of the wall of the tumor. This gray portion is the wall. We completely removed the tumor, and just show you the post-op scan. So this is the SACPs and MEPs after resection, almost equivalent to the baseline MEPs and SACPs. Post-op, this is the post-op imaging showing no blood products, no cut or no hemorrhage. Post-op, he was ventilated for 48 hours, conscious, obeying, no diplopia, and facial improved after 3 to 4 days. Able to swallow the liquids and solids, able to walk, discharge with follow-up advice. Histopathology showing high cellularity and necrotic areas. And also the Rosenthal fibers were mentioned in the histopath. Tumor with the increased cellularity, and Ki-67 was diffusely positive. This is histopathology showing 20% areas of high proliferation. They have given us the pilocytic astrocytoma on the basis of Rosenthal fibers, but advised HC. The final histopath report came out from the Tata and came out to be glioblastoma grade 4 on the basis of the microvascular proliferation, mitotic activity, and scant areas of necrosis, but no Rosenthal fibers seen on the final histopath. So diagnostic dilemma, what we thought initially, it was a benign lesion, probably looking like a pilocytic astrocytoma. What it came out to be was glioblastoma. Clinically, there was short history of symptoms, but there were no signs of hydrocephalus, no internuclear ophthalmoplegia, no long tract signs, and no focal limb weakness. On the imaging wise, the lesion was located to the pons, well localized, well demarcated expansile mass. There was no diffusion restriction, minimal edema, cystic, and no exhepatic extension, and the tracts are displaced. Intraoperative morphology was of benign tumor. There was no evidence of necrosis or hemorrhage, and frozen was supportive of benign. Even the first histopath was showing the pilocytic astrocytoma. So the planning difficulty was the consideration of approach, as the tumor is not approaching to the coming to the surface from anywhere. The best possible approach, as per looking after the cortical spinal tracts and all, the imaging we considered as going to the fourth ventricular floor. We used intraop sonography and intraop neuromonitoring as the modality, supporting modalities for this tumor. This is the WHO classification showing the glioblastomas and diffuse midline gliomas of the grade 4. And first MRI classification given in 1991 for the brainstem gliomas, obsolete now. And then in 2017 they are saying we have another classification, but the diagnostic dilemma is key for this kind of tumors. Those look like a benign one. What should we do? What is the ideal approach to be taken? These are the references. I just want to ask you, what is the open question to the floor? What is the opinion? Also, on the basis of imaging, on the basis of clinical findings.
Benign tumors are so rare in pons that we were completely fooled by the appearance of the tumor. And though the patient has not come to any suffering, we would like to know what others would have done. I would appreciate any comments.
Yeah, can I comment?
Yeah.
Yeah, see, I think we are also presenting a series of the brainstem tumors. It's a CME lecture. So I think Dr. Harish also will be discussing what we have also realized. This is a similar case when the frozen, we have operated the frozen. It was a sort of a diffuse one. But when I went in, I normally take the lateral approach. I don't go through the fourth ventricle anymore because the morbidity is too high. As far as the intra-fourth ventricular approach, I do a supra-trigeminal approach, which they will be showing. And you're able to get a lot of tumor out in that approach, in my opinion. Of course, we use the navigation, we use the monitoring, and we use the ultrasound also. And a similar case, it turned out to be grade 1, low grade on frozen. And the Tata, after they did the IHC, it came out to be grade 4. So I think we should not underestimate the tumors, but the moral of the story is we should go chasing them, because such big tumors, they say give radiotherapy directly. I have changed my policy. I need to debulk those tumors before sending for radiotherapy. What is your opinion, Dr. Dev Pujari?
No, that is why it was so localized, the tumor, no perifocal edema, no diffusion restriction. And the patient was relatively intact, did not have any cross signs like internuclear ophthalmoplegia. I thought it was worthwhile going for surgery.